Good afternoon, everyone. Thank you for joining us for another Journal Club. Today, we will be talking about creating and managing a COVID-19 designated unit. And we're very fortunate to have some special guests with us. I'm actually going to turn over the meeting to them, which is a little different than what we normally do, but they have such great information. We want to kick it off right away. So, Connie, I'm going to turn everything over to you and Carmen for introductions. Thank you.
Thank you very much. So I am with LeadingAge. I'm the compliance officer with LeadingAge. So our job is to help keep our members in compliance with all of the guidelines, regulatory guidelines. That's my role. I've been practicing for many years in long-term care. So LeadingAge represents, we're one of the only associations that represent all of the continuum. So we have IL, AL, and nursing homes. We have 250 communities here in Florida that LeadingAge represents just in Florida. We offer the educational, just like sessions like this, as well as legislative and government agencies and liaison with the agencies, which during this COVID period can be very difficult. During the pandemic, since the beginning, since the governor issued the first emergency order, LeadingAge has managed all of the directives to the nursing homes, which include CMS, ACA, OSHA, Department of Health, the governors, and the Department of Emergency Management. And we have had over 110 directives to the nursing homes since March 1st, to the nursing homes and the ALs. In the beginning, we held daily calls 7 days a week, and now we're at 3 days a week. So we look at all the CDC documents, which, as you know, have been voluminous documents. We look at everything, and then we provide it back to our members. So what we wanted to do today, and then we answer questions 7 days a week. Let me know, so you know that. 7 days, 24 hours a day, we're on call to answer any question from any of our members. So what we wanted to do today, many people don't have an opportunity to see a COVID unit. And I've been with Morris Life for about 12 years. And so I've watched them through this pandemic, and they've set up an incredible COVID unit. And it came to my awareness, people don't really get to see this. So I asked them if they would be willing to both videotape and to share with everyone else what they did in actually establishing the COVID unit and then how they manage it now. So I'm going to turn it over now to Dr. Dhana.
Thanks, Connie. Before we get into the nitty-gritty of the COVID unit, I think one of the important things is for an organization is to try and figure out if they need to open a COVID unit. Okay? Have a little technical difficulties here. So the first thing that you have to look at is the size of your organization. If you have enough patients, clients, where it's feasible to start a unit. At Morris Life, we have several different entities on our campus. We have a 310-bed nursing home. We have 52-bed memory care assisted living, 150-bed assisted living, over 180 unit independent living, and over 700 clients in our PACE program. That's a total of over 1,400 clients that we're in that we're providing direct care for on our campus. So for us, we felt it was inevitable that eventually some of our clients would come down with COVID positive or with test positive and would need to be in some sort of isolated setting. Some other factors that you have to take into consideration is what's going on in the community. Too far, one more back. What's going on in the community? What is the % positive rate of COVID in the community? Is it increasing or is it decreasing? Obviously, if there's not a lot of COVID in the community and the numbers are getting lower, then it's probably not worthwhile to open a COVID unit. But if you have a high percentage of positive patients and it's getting worse, then you may really want to start looking into opening your own COVID unit. Also, you want to look at the local hospitals and see what's going on there. Here in Palm Beach County, our hospitals early on in the pandemic were clearing out, making room for the wave. And they're also told us they're not admitting COVID positive patients who are asymptomatic. So that, that forced us to have a plan to take care of our patients that were COVID positive. And in Florida, we have state-designated SNFs that are COVID-19 facilities. The closest one to us is in Deerfield Beach, which is about an hour drive from here. So we felt it was not appropriate to send our patients on an hour-long commute away from us. But if you have one of these facilities close by next door, it may not be worthwhile for you to set up your own COVID unit in your facility. And then finally, if you have the number of patients and you have a lot of COVID in the community, then you have to look at the facility and see, can your facility pull this off? So you have to look at the physical layout of your buildings, and you need to find somewhere that can be isolated completely from the rest of the nursing home. You also have to look at your resources. You have to look at your staff. Do you have staff that's willing to work in a COVID unit? Are you well-staffed, adequately staffed? Do you have the money necessary to purchase all the additional equipment? And Robert and Carmen will talk about this later on. And then very, very critical is the PPE inventory. You have to know what you have on hand. You have to know how much you're burning right now, your burn rate calculator. And you have to adjust it for the increased use with a COVID unit because you're going to be burning more PPE with a COVID unit. And then just as critical is your supply line. Are you able to get PPE to replenish your supplies as you burn through them faster? You also want to look at your liability exposure, your positive patients in your facility. You want to look at the long-term care residents who are there, how they're going to look at that. And also your staff. You're going to be exposing your staff now to COVID positive patients. So you want to make sure you have adequate PPE and your staff dying as well on doing the COVID unit. And then finally, you want to look at your public relations exposure because some facilities have had negative PR exposure from, starting to take COVID patients. So like all things COVID related, our COVID unit is over time with multiple changes. So after we went through and we saw a large number of patients, there's a lot of COVID in Palm Beach County, and we had the resources and the staff buy-in to go ahead and open the COVID unit. We started a 13-bed COVID unit. And initially, there were no tests available to the facility or in the community. It was all done in the hospital setting. So we really had no COVID positive patients in our unit. It was kind of empty. So with our PACE clients, we had clients in the community who needed skilled nursing care but weren't sick enough to go to the hospital. So these are patients who are living in homes, assisted livings, etc., who needed a higher level of care. So we decided to take these patients, and instead of just admitting them to the regular nursing home floor, we took them to our COVID unit. But since it wasn't COVID, we nicknamed it the hot zone. So we took them into the hot zone, and we kept them there for 14 days. And then once they were asymptomatic after 14 days, we then transitioned them to the regular nursing home floor. But what this did, it allowed us an opportunity to actually look at all of our processes and procedures to see what was working and what wasn't working. We looked at our flow of, staff, food, medications into the unit, off the unit, just how things were running, how the donning and doffing procedures, signs, etc. We just were able to streamline it before we actually got a COVID positive patient. So in early May, we had our first positive patient in the SNF. And at that point, we had to basically flip the switch, so to speak, and turn it now into a true COVID positive unit. And we had to stop all those PACE admissions from coming in who were just being quarantined. Fortunately for us, next slide, we didn't have a lot of COVID positive patients in our facility, so our occupancy was really low. Even though we're testing in our SNF, we only had about 20 to 30% occupancy. And just so you guys know, the discharge criteria from the COVID unit in those early days was 2 negative PCR tests greater than 24 hours apart. Once you met that criteria, you could then be discharged or transitioned to the regular nursing home floor. So due to our low occupancy and the fact that we're already taking care of COVID-positive Morse Life clients, we decided to open up our unit to non-Morse Life clients who were in the hospital, who were waiting for those 2 negative tests. But we decided to take patients from the hospital who had 1 negative test, who didn't quite meet the 2 negative tests. So we started admitting those patients to our facility. That helped the hospitals a little because they could start discharging their patients a little sooner. But then in July, or right after July 4th, we had this huge surge here down in Florida, and all the hospitals got really backed up with COVID admissions. And then the hospitals actually started reaching out to us to start taking COVID patients who didn't have any negative tests. So we worked with the hospitals. They came over, they toured our COVID unit. They looked at, all of our different systems and procedures, don and doffing, our, air handling unit, all that stuff. And they basically gave us a thumbs up that we're doing everything great. And we started admitting COVID-positive patients from the hospital who didn't have any negative tests. But we didn't just pick anyone. We actually set up admission criteria. And apart from the obvious, making sure the patient is medically stable and hemodynamically stable, we wanted to make sure that their O2 sat, their oxygen saturation, was appropriate. And we used 94% as a cutoff, and that was based on the CDC basically stating that if a COVID patient's O2 sat was on the lower side of 94%, they probably should be in a hospital setting. We required a 94% or higher to be admitted to the COVID unit. The other thing we did was that we did not want patients wandering from one room to the next. Even though all the patients were COVID positive on that unit, we wanted to make sure that they were isolated in their rooms and that they weren't commingling. So we didn't accept any patients who were wandering. And at that point, the discharge criteria was still the test-based strategy, 2 negative tests greater than 24 hours apart. We also created an admission order set, and this was mainly for patients who were diagnosed who became COVID positive here in the facility that were then transferred to the hot zone. And this admission order set was based on inpatient guidelines created by Mass General Hospital. They're obviously geared towards inpatient hospital care, but we decided to, use them maybe a little over the top, but I figured we'd just go all out and do everything on our patients who are staying here with us. And if they became unstable, then transfer them to the hospital. This order set, go back one more. This order set also included, if antibiotics should be used and what type and how long and so on. And then we also use AMDA's guideline on VTE prophylaxis to kind of encourage all patients who are COVID positive to be on an anticoagulant for up to 45 days. And we really encourage the use of Lovenox, which was Lovenox, but there's different options. And also to consider full anticoagulation if the D-dimer was significantly elevated. And this guideline is available on the AMDA website. And then the other thing is that we wanted to make sure that no patients were getting any kind of aerosol generating procedures, for example, like nebulizers or CPAP machines. We switched everyone over from nebulizers to MDIs spacers. As for medical staff visits, majority of the visits were done via telemedicine with the help of the nurse in the unit, using either iPad or iPhone. We basically used FaceTime. It was the most efficient way to carry out the visits. And it was really left up to the discretion of the clinician if they felt they needed to do a face-to-face visit in the unit. But that was the minority of cases. Most of them were done via telemedicine. And then the only other most recent update was back in mid-July, CDC actually changed the criteria for discontinuing precautions. They're now recommending the symptom-based strategy, which basically says that if you're asymptomatic or if you have a mild, moderate infection, you can discontinue precautions 10 days after you tested positive if your symptoms are improving and you've been afebrile for more than 24 hours without an antipyretic. And then 20 days for patients with more severe infection or immunocompromised, also once again, improving symptoms and being afebrile for more than 24 hours. So now I would like to turn it over to Carmen Shell.
Thank you, Dr. Dhana. This is the floor plan of the Mack building. The pink is the actual 13-bed positive COVID unit. The staff enters through a courtyard into the orange dot, which I'll go over with the video. The blue dot is the, so to speak, natural barrier, which are double fire doors. So that separates the positive unit from the rest of the Mack 1 unit. And the yellow off to the left is the doffing space, and it exits to the outside. So now I'm going to switch to the video.
Screen sharing.
So this is just an introduction to more slides. The first thing you'll see is an overview of the campus. The Mack building is this building, and the hot zone is housed on the ground floor. And this is the main entrance into the Mack building. And this is the entrance for the positive COVID unit through the courtyard garden into the dining space with appropriate signs. The only staff who enter are those staff who are working there or delivering supplies. One of the issues that we found is that it's very important, one, to organize all of your PPE to keep the space clean, and to always have visual cues to make sure that staff consistently applies the PPE properly and in the right methodology. We use washable gowns, and we supply each staff member with 4 N95 masks every 2 weeks, which they number 1, 2, 3, 4, and with an associated paper bag for storage of the N95 masks. We also prefer to use the face shield over the face goggles, and we've included the hair covers and shoe covers, which are not mandated, so to speak, but our staff prefer them, so we provide them. The nurse manager zips through the visqueen into the COVID positive unit, unzips, and we'll see the ionization technology that we use on contaminated surfaces and high-touch areas, which Robert will discuss later in the presentation. And then we have a combined nursing station and kitchen, and in this kitchen, all food, snacks, supplies are for the patients and the staff. Everything is served on disposables. Nothing goes through the dish machines. We have a break room for the staff because once the staff enters the unit, they do not leave the unit until the end of the shift. So the restrooms, when we supply all their meals and snacks, this is one of the large HEPA filters in the hallways. And again, Robert will talk about the air filtration system. And now we move from the hallway into a patient's room where therapy is being delivered. The patients typically would wear an N95 mask. This resident patient is unable, and just the therapist cleaning the equipment between patients. We felt that it was necessary to deliver therapy even in the COVID positive unit since the residents and patients are stable. This is a patient's room with an inpatient HEPA filtration unit. We placed air mattresses on all 13 beds because we thought the patients would be compromised, and generally they have been. And this is our frame, which moves up for our oxygen supply system. And now we're going to begin to exit the room, go down the hallway to the doffing space. As we enter the doffing space, this is where any patient being admitted to the COVID positive unit enters through this space, and obviously this is where all PPE is removed. Again, it's even more important in the doffing area that the signage and the visual cues follow exactly the order in which the PPE should be removed. And again, the surgical mask over the N95 will be disposed of. Another key point is if you can, any of your trash barrels or your linen barrels, if you can have hands-free using a foot pedal, it's much better. It reduces the high-touch zones. Again, the shoe covers and foot covers, our staff likes them, so we continue to provide them. Also, where the nurse manager will place his gown is he's going to place it in a melt-away bag. So the melt-away bag prevents the porter from having to handle any of the linen or the washable gowns, and it also prohibits when the gowns and linen goes for main laundry. They're put immediately into the machines with the melt-away bags, so there's no sorting, there's no separating, and it reduces the possibility of transmission to the porters and the laundry staff. And our face shields, obviously we clean before and after the shifts, and we usually use the face shields for about a month. We use the CDC crisis strategy for the use of PPE because we always are looking at the worst case scenario, and we always question the supply lines. And this is an exit that goes immediately to the outside, and the staff members don't re-enter the building. They go immediately to their cars at the end of their shifts. So I'm going to, in just a second, switch back to the PowerPoint, and then we'll resume the presentation. So next slide. Just 1 second. Just want to review some of the critical features. If you make the decision to have a COVID positive unit space, as Dr. D mentioned, the unit needs to be isolated, apparently, obviously, from the rest of the unit. You need to have entrances and exits that are separated from the main entrances and exits to the building. You have to have and must have specific donning spaces and doffing spaces. Once again, you have to look at the PPE. I know CDC says that you can wear, if necessary, a surgical mask, but obviously it's more appropriate to have N95 masks, and we use our N95s covered with the surgical masks. So you need to have proper PPE, and as we mentioned before, a good supply of PPE that you can depend on. It's imperative that you have a break area for the staff where they can use the restroom, where they can have their meals and take breaks. Proper ventilation, Robert will cover that momentarily. Competent, committed staff. We compensate our staff who work in the hot zone. We compensate them for every shift that they work there. And we made sure that they were properly trained, and we staff with all registered nurses, certified nursing assistants, a culinary staff member, and housekeeper, and 2 rehab staff, 1 PT and 1 OT. Cleaning protocols, you have to make sure that the products that you're using are on the N list from CDC, and do the high-touch surfaces frequently. And when a patient is discharged, we use the ionization machine in that unit to sterilize that area. Physician and nurse practitioner support. Dr. D has reviewed with you, but it's also important that whomever is working with that unit, that the response is quick, and in the event that there is a change of condition and a need for higher level of care. Ability to test patients, residents, and staff is really no longer an issue. I mean, tests are available, plus we use the symptom-based strategy for discharge. You have to look at your traffic flow in your COVID positive unit, how do people enter and exit, how the supplies get into the unit. Nothing that enters the donning space, like a cart, does not enter the COVID positive unit. It's transferred at the zippered door, so to speak. So there's a cart within the donning space, and there's another cart for transfer within the actual COVID positive unit. And trash exits through the doffing space. Next slide. So this is just a couple examples, again, of the private entrance, and again, of some of the visual cues that you need to have in your donning and doffing spaces. Next. And this is, you're probably all aware of the CDC's recommendation for PPE for healthcare personnel who are working in a positive COVID unit, the face shield or goggles, the N95 masks, the gowns and gloves as appropriate, and we've added the hair and shoe covers. The wooden doors on the right-hand side of the slide is what we call the natural barrier. It's the fire doors that separate the positive unit from the rest of the Mack 1 unit. One of the things that we haven't mentioned is in the Mack building, and especially, well, obviously in the COVID unit, all the rooms are all the rooms are private with private bathrooms. And the photo on the left is just to recapture the nursing station and the kitchen that's on the unit. And again, I just wanted to go over how important it is with the handling of the linen and our washable gowns to protect your portering staff and your laundry staff. So on the right is a good example of a melt-away bag that's actually inside another clear plastic bag, which is inside of the linen hamper. So those, the plastic bags are removed, put into the golf cart, delivered through the back to our main laundry room. And as I said before, immediately put into the washing machines, still within the plastic melt-away bag, which dissolves during the wash cycle. Next slide. Now I'm going to turn it over to Robert to talk to you about the engineering measures in the unit.
Thank you, Carmen. Because the building was designed without negative air isolation rooms, we follow the CDC guidelines installing HEPA filters in the resident rooms and the corridors. These HEPA filters are sized large enough to give us 12 air changes per hour per the CDC requirements. Each of the resident rooms has an individual fan coil unit with a MERV 13 air filter that's installed, and these recirculate air within the room only. The air within the room does not return to the main air handler unit that supplies conditioned air to the rest of the building. Also, we make sure that all of the resident room doors are closed at all times so that we don't recirculate any of that air within the room into the corridors. We also have the HEPA filter placed at the head of the bed, typically where the patient's head is, and it filters up to 3 microns and 99.5% of viruses and bacteria within the room, and performs 12 air changes per hour, which meets the CDC guidelines. And also in the corridors, we place a larger HEPA filter in each of the corridors and it's large enough to recirculate the air 12 times per hour, again meeting the CDC guidelines. So it uses 2 HEPA filters and a UV light, and filters out 99.5% of bacteria and viruses up to 3 microns. And then we go to the air handling units. Each of the air handling units that supply air to the corridors are equipped with primary filters, which are MERV 13 filters. and that's pictured at the top. And then we have the secondary filters, which are actually the HEPA filters, and those are the metal filters pictured in the bottom. And then lastly, we put a global plasma generating system installed into all of the air handlers across the campus. So this system treats all conditioned air and ductwork and coils with harmless and odorless plasma gas that kills 99.4% of COVID within 30 minutes of contact. So, and then for as far as sterilization, we use the same concept or the same technology that we use in the air handler units, which is a portable system that uses a global plasma gas, and we treat all high-touch areas, the donning and doffing areas. After their discharge. The resident's discharge, we also sterilize the room, and we do that, and we treat all the high-touch areas and high-traffic areas daily. And for, I'll turn it over to Christopher Schell for lessons learned.
Hello, my name is Christopher Schell. I'm the risk manager for Morris Health Systems. Creating a COVID unit can be a very complex evolution. It requires a lot of attention. We've learned that it also requires a willingness to constantly review and revise your policies and procedures, both due to changing government guidelines and then the changing effect of COVID-19 on our community. One of the most significant issues we've come with, or we faced, that's been brought up multiple times, is the significant increase in the use of PPE that you will face. It is our recommendation that you have sufficient PPE to last at least 6 weeks under your worst case scenario. This was a much more significant issue in the beginning of the pandemic due to the supply chain issues that we all faced. But I would still recommend that you develop multiple sources of PPE so that you don't find yourself suddenly lacking. So we've been developing multiple contacts throughout the United States and overseas to ensure that we have access to our PPE. In addition, I have a warning, though, regarding specifically overseas PPE purchases. I would always request a sample prior to purchasing anything in bulk, because there are a lot of groups out there that are taking advantage of the pandemic and ripping people off, so beware. One of the first steps we did once the testing kits became available was we started doing fit testing for the N95 respirators for all staff that were working in the hot zone. One of the issues that we face that has been difficult to deal with at times is you need to make sure when you purchase your PPE, specifically your N95s, that you have a wide range of sizes, because otherwise it can be very difficult to successfully fit test an individual if you only have a limited supply of N95s. We found that by doing the fit testing, we saw an increase in staff morale and confidence working in the hot zone, because we had shown that we were going to take every step that was available to us based on the PPE limitations we had to make them feel safe. In addition, we've instituted a robust monitoring education system where we're constantly reinforcing procedures such as donning and doffing. I know it's been said multiple times during this presentation, but the simplicity of the instructions and the ability of things like mirrors to help staff members don and doff their PPE has been crucially important for us. And we found that once we simplified the process and we made it easy for people, no matter what department, whether they're nursing or housekeeping, it really improved our compliance. In addition to that, this is something you have to consider to be a truly interdisciplinary approach, because you're going to have to make sure that all of your staff, housekeeping, culinary, nursing, are all on the same pages and they're all kept up to date on any changes that occur. That includes things like maintenance department for setup and breakdown, ensuring that when patients are admitted, they bring the minimal amount of personal effects into the hot zone as possible. We found that we have the families after they're transferred out of the hot zone bring things in for them later because we don't want to risk exposing our staff to potentially contaminated items, or at least to minimize that risk. As we also said, make sure you have dedicated areas for your staff where they can go have their break because they are not leaving the unit as per our policy during their entire shift. So make sure that they have comfortable areas and they have adequate supply of snacks and drinks and things like that. Also, make sure that you try to the utmost of your ability to staff your unit with dedicated personnel, where they're not moving between one building on your complex or multiple floors in your complex. If they're in the hot zone, that needs to be their sole assignment, okay? Like I said, flexibility is key. Be prepared to deal with the unexpected. Things like wandering patients. If you don't know or you're not informed during the transfer, you might have someone with dementia who's incapable of not wandering. Think about issues like bad weather, and remember that medical emergencies happen on positive COVID units just like they happen anywhere else. So be prepared, have your staff ready, and make sure the staff that you put there is highly competent because they're not going to have the same kind of monitoring on the unit that they would normally have as part of the nature of the isolation. Okay. Another issue that we found is I would recommend highly that you have the ability to expand or contract the hot zone that you create. Okay? One of the reasons for this is that our occupancy has been highly variable. We've been full and we've had one patient. So we developed a system where we can, using our fire doors, expand and contract so that we don't have a large number of empty beds. Okay? And finally, one of the issues that you have to consider when doing this is the increased cost that is incurred by doing this. One of the first things we did is we went through and we looked at our air handling system because unless you're specifically designed as a negative air pressure, air is often shared through the air handlers through multiple areas of the building and multiple floors. So before you start this, you have to make sure that you have a system in place that you're not contaminating areas outside of a hot zone based on your airflow. Okay? In addition, you have to address the need for doing frequent large area sanitization. That's why we purchased the SteraMist surface unit as well as the gas plasma systems. By doing that, we are not only doing the frequent high-touch surface areas during the shift, but at the end of the day, specifically trained staff comes in and does large area sterilization as well as sterilization after discharge before we have a new admission. So just as an example of some of the associated costs, we've spent about $40,000 on the SteraMist sanitization unit. For our large area HEPA filters in the gas plasma system, that was about approximately $77,000. For the individual room HEPA filters, we spent about $15,000. And that's not including the constant need for additional expenses. Visqueen for the walls, tapes, brackets, touch-free trash cans. You just need to be cognizant of the size of your unit and what you're planning on doing, that there's a significant additional cost. For me, that's about it for me for lessons learned. So I'm going to turn it over to Connie, and thank you very much.
I think now we're just going to open it up for questions. So if people have questions or are here to answer questions, I want to make sure that everybody knew Carmen was the Vice President of Nursing, so that, and Robert, what your position is.
I'm the Senior Director of Facilities for the Mooreside campus.
Great, and then Chris, I think you said and everybody knows.
I'll say it again. I'm Stephen Shell. I'm the Risk Manager for Morse Health System.
I think everybody knows what that is. So we have questions. Any questions that people have?
So Connie, we did have a question that came in through the chat. The first one was, in the COVID unit, are staff members always in PPE, even during lunchtime? I believe it was answered, but just to clarify.
Yes, they're always in PPE. One of the things that makes our staff, again, feel more comfortable is over their washable gowns when they enter the patient's actual room, they put on a disposable gown, which basically keeps their washable gown clean, so to speak. So when they go into that break space, they just have on the washable gown.
And I
Okay.
think also what's important to say is that they stay on the unit. Once they enter, they don't leave the unit. And that's why the meals are provided. So Morin provides the meals for the staff so they don't have to leave the unit. And like Carmen said, they wear PPE all the time when they go into the break room. And that's something that we've learned not only for the COVID units, but for all of the facilities now, is what's happening in the break rooms. They're learning now that COVID is being spread in those break rooms. So as you saw what Carmen showed, you have to socially distance people in those, not only on the COVID units, but the other break rooms, and they do that on the COVID unit.
Okay. Second question was in regards to CCRC campuses in Florida. Are they mandated to place residents that they admit from home to the assisted living units on a quarantine for 14 days?
Okay, so that's a mixture with home and assisted living and long-term care facilities. So are you saying that they're admitting somebody into the assisted living that is possibly COVID?
Yeah, so sort of in that situation, I think Dr. Dhana described from the PACE unit, if they're coming into home and they're going into assisted living or even, I guess, into the SNF, would they be mandated to be on quarantine for 14 days?
What we have done here is that we're required, because now early on we did that for 14 days before testing was more available.
Mm-hmm.
So now that testing is more available, what we've done with our assisted living is that we've had them test prior to coming in, right? So we get a negative test, whether it's 2 days, 3 days, 4 days, whatever, before they come in. And then once they're in the assisted living, they quarantine themselves, and then we repeat the test 7 days after they've been here. And if they're negative again at that point, then we lift the quarantine. It's a little tricky in our memory care because those clients tend to be more mobile and also are less likely to, want to stay in their room and use a mask. So usually what we do is we work with the families and we tell them that they have to hire an aide to stay with the patient, and the aide is going to be in full PPE, and then we just wait the 7 days and test them again to make sure that they're, and obviously if they develop symptoms, it's a whole different ballgame, but if they're truly asymptomatic, 7 days in, and 2 negative tests, 1 before admission and 7 days after, then we feel they're pretty safe to mingle with the general population.
As far as admissions into the hospital, Florida is fortunate that the Agency for Healthcare Administration here has issued orders to the hospitals that they are not to transfer anybody COVID positive or possibility of COVID positive unless they're transferring them to a COVID unit. So they must test in our hospitals here before they send them to the facility.
Thank you. Do we have any other questions? So I'll ask one while we're waiting for any other participants to generate questions. You mentioned the cost of all of this. If there are facilities who are struggling with managing the upgrades and the equipment that they would need to bring it to their facilities, what should they do? Is there an avenue through LeadingAge that they can work with LeadingAge to help them to get their needs met?
Well, they just need to make sure that they're taking advantage of all of the opportunities for funding that is out there. Through the CARES Act, through different avenues, those are just more of your finance people, but there are opportunities for funding. And I'm sure that probably LeadingAge International has a list of all of those, but facilities that have applied for that COVID-specific funding, that has helped.
Yeah. And we would also recommend that what we've done here is we're very specific with every single expense that we generate that is COVID-related is all put in our COVID file for eventual filing with FEMA and other organizations. But our finance department has been very diligent and making sure that we capture every single possible expense so that if we ever do get reimbursed by FEMA or by any other government organization, we'll be in a much better situation to show exactly and with detail what it's cost us.
Right, those loans that were done early on, remember there were loans opportunity for facilities, and many facilities applied to that and received those funds. Those funds have to be used for COVID, and that's why, but they can be used for many things, purchasing of PPE, purchasing of consultants that come in and help set up the units, purchasing of special equipment. So as long as those funds were used for COVID, then those funds will not need to be paid back.
The other thing that you have to think about if you're setting up a unit is where the unit is located. You may not need to spend all that money on air handler, HEPA filters. If it's a building that's by itself, literally separate from the rest of the other buildings.
Yeah,
because we had a shared air handler, we had to go overboard and make sure that we have all those extra systems in place.
Yeah.
But in reality, if you're just like a house, if you think about house and it's about all COVID patients in that house, you wouldn't need to go through those extra costs.
Yeah. So each building is designed differently. So it would depend on their their HVAC systems. Do they have negative air isolation rooms? If you don't, then use HEPA filters. Each system has to be looked at individually in each building.
Okay.
Hi, Dr. Diaz. Can I say something real quick? Can you guys hear me?
Yes, we can hear you, Dr. Diaz. Go ahead.
So one of the things that I found that were very, very important for us, and we had a large number of COVID positive patients, was that we dedicated specific personnel towards getting rid of the trash, getting someone to answer the phone so that the nurses could stay on top of the patients, but dedicating people to do specific tasks and not allowing people to do multitask stuff because that took them out of their game. And that was very, very important for us.
Sure, and as far as the cost, remember, everything has changed so dramatically since March 1. What we say with COVID is nothing stays the same. So remember in the beginning, people were staying in the COVID units longer. Once the 10-day symptomatic, came out, people are not in the COVID units as long as they were before because you're able to clear them in the 10 days. So things have really changed throughout the process, and as the doctor explained too, tests are now available more readily. We're getting more clear information of patients that are coming into the facility. So definitely, I think those help decrease your costs.
Oh, thank you. And we had I think another question around the disposable gowns. Are those gowns red bagged or are they discarded in a different way?
No, there's no need for them to be red bagged. They're just disposed of in the trash. And just like Dr. Diaz was saying, there's dedicated staff, routine staff that pick up on a schedule all of the trash, the soiled linen, and the washable gowns, and take it immediately to the dumpster or to the main laundry.
And then I think that also speaks to the over expenses that are not necessary. Sometimes when I go in facilities and they're red bagging, you follow your standard infection control, and so only if you have the potential to spread blood items that are bloody would you use a red bag in the COVID unit. Otherwise, like Carmen said, it's not red bagged.
So I have we have received a question about, medical directorship and the QA process for this unit. Is it separated out from the rest of the facility, or are you talking about and discussing the challenges at the same time as your standard QA process?
It's all part of it's all integrated. As a medical director for the entire nursing home and chief medical officer for the entire organization, there were multiple hats. But as far as medical directorship of the unit, I oversee the unit, and it's all integrated.
Yeah. And Dr. Dhana, you wear 1,001 hats. So.
True.
Are there any other questions for the Morris Life team? If you think of a question, we'll definitely be able to get it to their team via email. So please email myself or Shane. We will also make this presentation available on our website and in our library. And I thank you all for sharing such great information with us. Thank you for the video of that tour was amazing. Thank you.
Thank you for the opportunity to share it with everyone.